all of you. As usual, I'll start with a short case first. Can you see my slide?
Yes, sir.
Can you see? Yeah, right. So we'll start with the short case first. It's a story of an 81-year-old man. His complaints of twitching movements of left arm for the last 3 months. That's only complaint. It is not present all the time. Duration is variable. No other complaints. No pain, weakness, or paresthesia. This is the twitching movements of the hand. But it is noticed the biceps, but it's partially flexing the biceps. See the movement. Something like a continuous fasciculation is going on like that. It's not a random, almost continuous. It disappears. Quickly on extending and partially flexing, it disappears. Full extension also it disappears. Not present now when it's fully extended. Examination is tone, power, normal. Even the biceps power was break muscles normal. Left bicep
ഞാൻ ഈ കുത്തുന്നതൊക്കെ ഒരുപോലെ അറിയാനല്ലേ രണ്ടും ഒരേപോലെ ഇതറിയാമല്ലോ ഇതറിയാം.
Okay, so findings: twitching movement of the left biceps, especially when the elbow is partially flexed. It becomes attenuated on extension of the arm, suggestive of Curie fasciculation. Rest all normal. So what is the likely diagnosis in this patient?
Hyperexcitable state, probably neuromatonia.
Yeah, but it's only confined to one muscle only in the biceps.
Sir, the differential diagnosis would be like that. Yes, sir. First, we think about whether it is a fasciculation or not.
Correct.
This is number one. Number two, whether it's the myokymia. Whether myokymia means it may be a benign myokymia. Sometimes, the elderly patient we can have. Then the third differential will be a continuous muscle fiber activity like this or not.
Okay.
Then myotonia obviously would be the last thing we will consider.
But I agree with you. More like a fasciculation is more likely repeated fasciculation. The only point again is myokymia. Myokymia is usually like an undulating movement, like a bag of worms. That kind of movement is not seen here. It is something like a twitch, repeated twitch, which is irregularly present. Something like a continuous fasciculation which is seen. That is what I thought. But if it's only confined to one muscle, that's a problem. Okay, what will you like to do in this patient? So I thought it's a motor unit hyperactivity state confined to one segment. Maybe irritation of one root or irritation of the anterior console by something. That's a possibility I considered. Because only confined to one segment. So this is a compressive radiculopathy or irritation of the anterior console. So
but other muscles supplied by C5 root are not involved.
Yeah, that may not be. Suppose it's only a pool of the pool of anterior console. only few ventricles are irritated, or some of the fibers are only irritated. Sometimes it may only affect that thing. Again, there is no weakness, so it's only irritation. So that's a possibility you have to think. Okay, what test you want to do? To differentiate
And
myotonia or neuromyotonia or myokymia or fasciculation.
EMG.
EMG and
Okay.
CV.
Okay, EMG was done. This is the EMG of the corresponding muscle. See, the potential comes. See, this is one potential. Again, it comes repeatedly, then becomes more frequent. That's more frequent like that. This is at rest. This is not patient is not doing any voluntary activity at all. Absolutely keeping at rest. The repeated fasciculations appear. Sometimes irregular. Not like a voluntary motor reflex. You can see the twitching of the muscle with that at the same time. Like a repeated fasciculation, like a myokymia pattern, like a rusting sound.
കൈ മടക്കണേ, ഇങ്ങനെ പതുക്കെ മടക്കണേ. ഇതല്ല, അങ്ങോട്ട് അങ്ങോട്ട്.
Now jumping to the So single motor unit is firing irregularly. Now what will you like to do? Any other investigation you want to do?
MRI.
Yeah,
MRI of the cervical region.
Yeah, correct. Because we want to know, is it some root is compressing or the anterior console is getting irritated? So as for an MRI, so I'll show the MRI. Now this is on the right side. For comparison sake, this EMG is silent. There is motor unit, and you can send it to okay. So this is MRI. This MRI. Between C4 and C5, you can see the hyperintensity in the cord anteriorly, in the region of anterior horn cell. This is again, you can find that hyperintensity there. Exactly in that corresponding segment, corresponding C5 segment. This is the axial C2, C3, no problem, except for the osteophyte compressing anteriorly. It's again, no cord lesion, cord signal is the same. Nothing in the anterior horn cell. Now you can see C4, C5. So you get a hyperintensity in the anterior horn cell. It's something like a snake appearance anteriorly. Bilaterally present more on the right side. Again, you can find the classical snake eye appearance. So there is ischemic anterior horn cell loss, and the ischemia is most likely secondary to the osteophytic compression of the cord. See the compression of the cord there anteriorly. Dorsal spine normal. So this is a cervical spondylotic compression, ischemic myelopathy causing ischemic anterior horn cell loss causing irritation. So any questions?
So what is the distribution of this usual anterior dorsal injury in cervical myelopathy? Is it in the periscapular region or in the small muscles of hand?
No, usual thing is in high cervical cord, the first thing loss will be the small muscles of the hand. All other thing depending upon which segment is affected. Suppose the disc is compressing at C5, C6, that corresponding segment will be affected by the anterior horn cell loss. Because the ischemia compressing on that area. Because essentially it is compression of the anterior spinal artery or venous stasis. These are the two things cause the anterior horn cell loss. In high cervical cord, it is thought to be due to the venous stasis because the veins drain upward in the cord and then become superficial above C3. So when that is compressed, you get a stagnation of the venous vein at the CAD1. Then you get a anticonceptive loss. The other thing with the ischemia or due to the compression, the antispinal artery can occur wherever depending upon where the site of a compression is. Here it is happens to be at the C5, C6 segmental level, and the compression is present above downwards.
Okay, sir. What is the reversibility of this wasting and anticonceptive changes with surgery? Is it reversible or?
Anticonceptive loss is lost. It will not be reversible. Only thing it can prevent further progression.
Okay, sir.
So what is the management line surgery?
In this case, I did not advise surgery because there's no other deficit. So I asked him to wear collar as far as possible, avoid weightlifting. Let us follow up the patient if is remaining static without any problem. There's no weakness at all. Then we'll wait. Otherwise, it's any evidence of any progression, then surgery is advocated. Because I have seen cervical spondylotic myelopathy severe with compression of the cord who are denied surgery, remaining static for years together, 10, 20 years remaining like that without any worsening. I asked them to wear collar when they travel about that when it is likely to move. At that time, they asked to wear it. So it's quite unpredictable which patient is like to progress, which is not going to progress, which not. Because he is otherwise all right. Suppose he operates, something happens following surgery, then again it will be a problem. Okay. Shall we go to the next case?
Yes, sir.
Okay. Now, this is a story of a 70-year-old man. His complaint started as pain in the left shoulder 1 month prior to admission. This was followed by numbness of the left hand, which gradually ascended over the left forearm in 1 week's time. In another 1 week's time, numbness spread to the left side of the body. So initially pain, then numbness of the left hand, then left side of the body. For the next 10 days, patient noticed difficulty in walking in the form of unsteadiness of gait and clumsiness of the left foot while walking. History of precipitation micturition for the last 5 days. So initially pain in the left shoulder for 1 month prior to admission, then followed by numbness, which later on extended to the forearm, then entire left side of the body. Then for the next days, patient noticed difficulty in walking, mainly with the left lower limb. And it's a history of precipitation micturition of the last 5 days. So next, look at the hand now. Look at both hands. Left hand goes into athetotic dystonic posturing. He is continuously moving, even with eyes open. Ask him to close eyes, it becomes more. It goes upward a little bit. It's the dystonic posturing of the left hand. Ask him to open the eyes. Again, there's not much mild difference is there, but still more aggravated by closure, but it's still present on eye opening. So, power with 4 plus power of the proximal muscles. Resistance was weak. Finger resistance was also weak. Hand grip was weak on the left side. His left hand movement is clumsy. Again, the athletic movement. See the thumb finger has gone into adducted position, indicating dystonic contraction. The index finger is moving out from the fingers. He's looking at the hand. Still, the hand goes into abnormal posturing. And the wrist goes into flexion. made him lie down.
കൈകിനെ വയറ്റത്ത്
Kept
വെച്ചോ
the
ബലം
hand
കൊടുക്കണ്ട
on
അവിടെ
the
വെച്ചെന്നാ
left side.
മതി
See
ചുമ്മാ
what is
വെച്ചോ
happening in
ചുമ്മാ
the left
വെച്ചോ
hand. It levitates upward spontaneously without its knowledge. He's not asked to do anything. Spontaneously it goes up. Come to the reflexes. Right upper limb reflexes normal. All reflexes on the left
ബലം
side is
കൊടുക്കണ്ട ബലം
absent.
കൊടുക്കണ്ട
Biceps supinated,
ബലം
triceps.
കൊടുക്കണ്ട ചാ ഉത്തരം വേണ്ട പകുതി
Reflex is also absent on the left side. Both knee and ankle legs are brisk, more on the left side, bilaterally brisk.
Right.
Right panaverous flexor, left is extensor.
ചെറുതായിട്ട് അല്ലേ
The lower limbs normal.
കൈകിനെ ഇത് കുഴപ്പമില്ല
Then vibration and joints is impaired in the left hand.
പിഴ ഇല്ല
He could not feel.
ഈ വിരല് മുകളിലോ താഴെയോ എന്ന് പറയണം ഇപ്പൊ എങ്ങനെയാ താഴെയാണോ മുകളിലാണോ കണ്ണടച്ചോ ഇപ്പൊ എങ്ങനെയാ ഇപ്പഴേ ഇപ്പഴേ ഇത്
That is totally lost on the left side. He could not see where it is. So on examination, cranial nerves normal, tone normal, power left upper limb, left deltoid, triceps, wrist muscles grade 4 plus. Main weakness was the left finger flexes, small muscles of the left hand, which is grade 3 plus. Right upper limb power normal. Lower limb grade 5, both the lower limbs. Medial left upper limb all absent. Right upper limb biceps supinated plus, triceps is 2 plus. Lower limb reflex is brisk bilaterally. Plantar left upgoing, right indefinite. Sensation impaired vibration joints in both hands, more on the left side. There are other findings: dystonic athetotic posture in the left hand and arm levitation on the left side. So where is your localization and likely possibility? If you want the findings once again, I can tell.
It's okay, sir.
But
So he has got the combination of both upper as well as the lower motor neuron signs.
what is the lower motor neuron signs is
More
not?
lower, upper as well as the lower, sir, because the upper limb there is no jugs. Jugs are absent. All the jugs,
Right. Oh, that way. Okay. Right.
all
Okay.
the jugs are
Reflex,
absent.
yeah. Right.
And in the lower limb, the jugs are brief as well as the plantar extensors are on one side. He has
Correct,
also got the involvement of the posterior column, especially in the both upper limbs, the mainly predominantly in the left side of the upper limb.
Very good.
So,
Correct.
so this, if you consider this thing with a short points of history, the likely site of lesion should be the cervical region.
Yeah.
So, are you dealing with a case of cervical myeloradiculopathy or not? That should be our first thing. Or
Okay.
it's so in that way I will proceed, sir. So
Okay. Very good. So, cervical radiculomyelopathy can be intramedullary lesion also.
yes, sir, because of the bladder findings at this present moment also.
Right.
So we will have to think about the intramedullary lesion.
Okay.
And maybe the disproportionate involvement of the posterior column in relation to the spinothalamic. There is some sort of a dissociation, we can say like that.
In fact, he did not have any pain loss at all.
Or he has not no pain loss.
No pain loss at all. No pain and temperature loss. Only posterior column. And what is causing his athetosis dystonia?
That is most likely to the posterior column involved.
Correct. Now, this case I brought, mainly to show last week, we had a discussion whether posterior column loss can produce true dystonia or not. Here, even with eyes open, he has got abnormal dystonic contraction. So that's the point I'm trying to drive at. So it is need not necessarily be a pseudoathetosis or a pseudo dystonia, which occurs only at eye closure. Even with eyes open, sensory loss can produce severe dystonia. Okay, I'll show 2-3 cases also. So that's what he said is correct, exactly. And this is what the patient had.
Then should we use this term pseudoathetosis?
അതാണ് പറയുന്നത് നമ്മൾ pseudoathetosis എന്ന് പറയുന്നത് when you say pseudoathetosis, when the athetosis manifests with eyes closed and disappears when eyes open. That is the original term for pseudoathetosis or pseudodystonia. But here, even with eyes open, hand goes into abnormal position. So this is very well described in sensory loss, proprioceptive loss. And he has got a long intramedullary relation here, mainly on the left side, and with contrast enhancement, depicting the posterior column as well as the lateral column. And there's a contrast enhancement there. Irregular contrast enhancement. And this turned out to be a tumor, glioma. It was operated. So this is case brought only to show that the posterior column impairment can have severe pseudodystonia, or not pseudodystonia can have. So how does this already say? Arm limitation, dystonia, pseudothyrosis, and replacement conditional to posterior. So sensory loss even can produce arm limitation also. Arm can go on its own upward, like as you saw in this patient. I'll show 2-3 other cases. This is a story of it's a short cases, 2-3 short cases. A 52-year-old lady is still imbalanced while walking for the last 15 years. The imbalance is more at night. History of loosening of the chappals from both feet. History of paresthesia both legs for the last 10 years. Patient gave another history. Her legs will get lifted up on their own while sitting and while walking, which made her fall very few times. She said while walking, her left will go up on its own and will make her fall. Otherwise, she has got imbalance, paresthesia both feet, and loosening of the chappals, as you were most likely a sensory ataxia problem in that patient. I'll only show the cardinal finding in this patient. The interest of
മുള്ളോട്ട് എടുക്ക് തള്ളവരുടെ പൊക്കി പിടിക്ക്
the left is,
പൊക്കി പിടിക്ക്
foot is moving on its own.
കഴിഞ്ഞു
Bar was normal. Both knee and ankle
കൊടുക്കാലോ
jugs are
പന്തളം കൊടുക്കാം
absent.
ഇപ്പോഴോ
Vibration is
ഇല്ല.
lost over the both feet.
ഇല്ല
Also joint
ഇപ്പോഴോ
positions.
അറിഞ്ഞൂടാ
But let us see the way she walks. She has no weakness at all. Still, see the way she walking. And has got a positive rhombogism. She is sitting comfortably. See what is happening to both the legs. Both legs are moving on its own, mainly on the left side.
ഇതുപോലെ അല്ലേ ഇപ്പൊ അറിയാവുന്നതല്ലേ
It goes on its own.
ഓക്കെ ഇനി അമ്മ ഇനി കയ്യിലോട്ട് നോക്ക്
Then ask her to look at the
കയ്യിലോട്ട്
feet.
നോക്കിക്കേ
It is still repressive. On ask her to look at the feet. Still, it is present. It is not disappearing, even while looking at the feet.
കാലിൽ നോക്കിക്കൊണ്ടേ ഇരിക്കും അപ്പൊ അതാ എണ്ണത്തില്ല നോക്കണ്ട നേരെ എന്നെ നോക്കിയാ
Then keeping it on the stool
കണ്ണടച്ചോ
with eyes closed,
ശരി ഇനി കണ്ണു തുറന്നിരുന്നോ
with eyes open.
കാലിലോട്ട് നോക്കിക്കേ
Ask her to look at the feet. Even looking at the feet, the eyes legs moves on its own.
എന്നാലേ കാണാതായിക്കൊണ്ടേ ഇരിക്കുന്നത് അല്ലേ
Hamil function is normal. In motor system, upper limb tone power normal. No finger nose incoordination. No pseudothyrosis in the upper limb. Lower limb tone normal, power normal in all muscles. DTR absent in both upper and lower limb. Sensations upper limb normal. Lower limb touch pain normal. Impaired vibration and JPS over the toes. Rhombogism markedly markedly positive, severe sensory ataxia. And there are spontaneous movements of both feet in the form of twisting movements and slow deviation, more marked on the left side. Sometimes the legs get lifted up by themselves without her knowledge. These movements are not affected by eye closure. So this patient is motor conduction showed absent snap. Orbit parameter is normal. Diagnosis. Only JPS average lost only on the toes. but severe ataxia and pseudocytosis and dystonia. Power norm.
Plantar.
Plantar flex indefinite. No pyramidal signs.
Neuropathy.
Yeah, so sensitive.
SCD.
What is the peculiarity of what is this?
SCD.
Pardon?
Posterior column.
Impaired in the lower limb, impaired postural joint vibration lost on the toes.
Large fiber neuropathy.
It's mainly
Yeah,
posterior
yeah.
column tractopathy.
Yeah, right. But the peculiarity is that she's severely ataxic, no?
Yeah.
And this and this is one of the case of tropical ataxic neuropathy, which usually come across in central Travancore. They are markedly. Sometimes the sensory loss can produce even ballistic movements. I have seen, like throwing like a movements can occur in the lower limb. But you must have seen any number of diabetic neuropathies, no, with sensory ataxia. But they don't show this kind of a pseudocytosis and could severe ataxia. Still, they'll be able to walk about with eyes open. Only eyes closed, they'll be difficult. But these patients with eyes open or this thing, they'll be severely ataxic. Mimicking cerebellar ataxia. That is why the term itself, tropical ataxic neuropathy. And the postulate is that the main fiber lost is from the proprioceptive fibers from the muscle spindles. That is why the peripheral sensations are not much affected. The JP sensation really only might decrease, but ataxia is out of proportion. Something like a Miller-Fisher syndrome where the afference is coming from the muscle spindle, that is predominantly affected in tropical ataxia. Again, this case is about to show you the true dystonia can occur with sensory deafferentation. I'll show a similar case, a 60-year-old man. Now, this again, I edited the case to fit in our theme. What does this man have as the left upper limb? See, he has got a brainstem lesion, but that's not immaterial. Look at his hand.
കൈക്ക് ഒരു ചെറിയ മൂവ്മെന്റ് അത് നമുക്ക് ഭയങ്കര അസ്വസ്ഥതയാണ്. നമ്മളതിൽ തന്നെ കൈ തന്നെ കോൺസെൻട്രേറ്റ് ചെയ്ത് നിൽക്കുകയാണെങ്കിൽ അന്നേരം മൂവ്മെന്റ് ഇല്ല.
കണ്ണടച്ചാൽ കൂടും. കണ്ണടച്ച് സെൻസേഷൻ അച്ഛൻ കയ്യിലോട്ട് നോക്കണം. നോക്കിക്കൊണ്ടിരിക്കുക.
He's asked to look at the own hand, at his own hand,
നോക്കിക്കൊണ്ടേയിരിക്കണേ.
but still shows the normal posture.
ഇനി അച്ഛൻ കണ്ണടച്ചേ.
Posture does not increase much. With eyes open and closed, almost same.
കൈ മുറുക്കി പിടിച്ചോ.
And look at what is happening to the thumb. It gets adducted
ഇങ്ങനെ പൊക്കിക്ക്.
or otherwise normal.
കൈയുണ്ട് ഇതിന്റെ പാടായിരിക്കും.
The incoordination is there, so the wrist goes into
ഇല്ല.
no vibration, joints is impaired.
ഇപ്പൊ എങ്ങനെയാ? ഇപ്പൊ എങ്ങനെയാ?
താഴോട്ട്
ഇപ്പോഴേ
താഴോട്ട്
ഇപ്പോഴേ
മുകളിലോട്ട്
ഇപ്പോഴോ അറിയാം.
അതായിരുന്നില്ല.
He does not know the position of the hand. See, in walking itself, you can see the abnormal dystonic. So I did not mention about the ocular findings. He has got many other ocular findings. So the main theme was to show the athetosis dystonia due to he has also got severe impairment of posterior column. So his story is like this. His complaint started as acute onset of left-sided weakness, associated facial elevation to the left, numbness of the left face, and there was noticed a squint. The weakness improved to a great extent after 2 weeks, and on recovery, he found that he has defective vision and left hand would go astray and move away from without his awareness and even push the plates from the dining table. That is his complaint. His hand will by its own push his hand away from the dining table. This is the finding he had. He had lateral rectus palsy with the right lateral gaze palsy, acquired rotary pendular nystagmus, impaired vibration, JPS, impaired touch, defective osteognosis on the left side, left hand dystonia. You know what the patient had? The MRI. He had a pontine hemorrhage. Posterior pontine hemorrhage, mostly implicating the medial lemniscus, and of course, the ocular findings are due to that thing. and that is causing his medial eminence loss, producing severe proprioceptive loss and hand dystonia. So, any questions? I bought this only because last time we had a discussion whether true dystonia can occur in sensory loss. I said it can occur. I promised you I will show such a similar case. That is why I brought these 3 cases. Okay. Shall I go to the next one?
Yes, sir.
Okay. It's a story of a 50-year-old man, known case of diabetes for the last 3 years. He noticed 3 episodes of fall with buckling of the right knee 4 years back. Noticed difficulty in getting up from sitting position and climbing stairs for the last 3 years. Difficulty in lifting his right lower limb for the last 2 years. Burning pain over the right knee for the last 1 year. So I'll show the findings once again. Diabetes, 3 episodes of fall with the buckling of the right knee 4 years back. Notice difficulty in getting up sitting position and climbing stairs for the last 3 years. Difficulty in lifting his right lower limb for the last 2 years. Burning pain of right knee for the last 1 year. So go to the examination. Just put wasting of the right thigh compared to the left. See the wasting of the right thigh. Quadriceps is wasted. Tone is normal.
വയറ്റിലോട്ട്
Hypotonic. Right hip flexion is weak. Right hip flexion is normal.
ചവിട്ടി
Knee
മാറ്റണം
extension is normal on the
മുമ്പ്
left
ചവിട്ടി
side.
അതേപോലെ ഇത് ചവിട്ടി മാറ്റണം ചവിട്ടി
Quadriceps is also weak on the right side. Hip adduction and abduction normal.
ചേർത്ത് വെച്ചോ അടുത്ത സമയം
Adduction normal. Abduction.
തള്ളിപ്പിടി കീഴോട്ട്
Hip extension is also normal. Good power. Dorsiflexion normal. EHL normal. Plantar flexion normal. I checked the hip abduction lateral position. That is appear to be normal on the right side.
നേരെ പൊക്കിച്ച് നിർത്തണമേ
Hip extension is also normal bilateral.
മതി
The weakness is only hip flexion and knee extension. Upper hip pelvis is normal. Lower right knee jack is absent, even with reinforcement.
പിടിച്ചേ
Left knee jack is just elicible with reinforcement. And knee jack is absent on the right side. Left side again reinforcement just elicible. Myelin, plantar flexor. Sensory loss stretch is normal throughout, but pain is a decrease on the right side.
ഇവിടെ കുറവാ
Is a decrease on that side. Of the knee also it is decreased.
ഉണ്ട് ഇനി ഇതും ഇതും തമ്മിൽ വ്യത്യാസമാണ്
It's a different on the right side.
ഉണ്ടോ
On the dorsum also it is less.
ശരീരാണ് കുറവ്
We don't know for its label. Vibration is normal.
ഉണ്ടല്ലോ ഇച്ചിരിക്കട്ടെ ഇപ്പൊ എങ്ങനെയാ മടക്കി ഒന്ന് നിർത്തോ
Joint sense vibration.
ആ അങ്ങനെ പറഞ്ഞാൽ മതി ഇപ്പോഴോ മുകളിൽ നിഴയോ ഇല്ല അറിയില്ല ശരി
Sorry,
ഇപ്പോഴോ
impaired on the left toe is impaired.
ഇപ്പോഴേ
Right side is normal.
ഇപ്പോഴേ 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 ശരി മതി
Reverse SLR negative. No tenderness in the inguinal region. So this is the way he walked. As he walks, he put extra effort on the right hip, maybe due to the hip flexion. Maybe. So till the finding, Findings confirmed in the right lower limb. Wasting the right corticeps, which he says was there for the last 3 to 4 years. Tone normal. Power left lower limb all normal. Right lower limb weakness of right hip flexion and knee extension. Other muscles like hip adduction, hip extension, hip abduction all normal. All distal muscles normal. Detail right knee and ankle checks are absent. Left knee and ankle elicited with reinforcement, not very brisk, just elicited. Sensory system touch normal on both lower limbs. Impaired pain over the right thigh, knee, and over the right leg. Vibration normal in both the lower limbs. JP sensory, it's a decrease on the left side. I do not know. That's what he's sending. All the things on the right side. On the right foot, he felt correctly. He said he did not know. Maybe correct or wrong, I do not know. But he's consistently telling pain is decreased. His complaint is also numbness on the knee. Or except pain is decreased on the knee, that is almost certain. One time he said he decreased on the thigh as well as on the medial leg also he was telling it is less. So Patrick test reversal is negative gait, very mild dragging is due to the big plates, I don't know. So where is the localization?
Predominantly right femoral now, sir.
Right. So typically if it means the right reflection is weak, knee extension is weak, and adductor is normal, so more like a femoral neuropathy. The sensory loss also can go with that thing. Okay. Any other possibility you like to keep in mind? Can be
plexus.
Diabetic
Yeah,
hematophysis.
yeah, diabetic hematophy is a possibility. Again, that's again comes under femoral neuropathy. But it did not complain. It has been there for long duration, say about 3 years it has been there. And it did not improve also. And it progressed over a period of time. That's little odd for a diabetic hematophy.
Other possible could be anti-horn cells, sir. Except for the if you exclude the sensation, decreased sensation.
But that is his complaint also. I agree with you. It could be, but he complained. Otherwise, he would have ignored his findings. Many people, the affected say their tendency to trade is decreased. But since he's complained also, you have to take it that it is present. So the other possibility can be L23 for radiculopathy, adductory aspect, but the weakness is not gross, no? So sometimes mild adductory weakness can be missed. You cannot examine the corticeps just like I cannot examine the adductor just like you examine the corticeps, because you cannot put a resistance so forcefully. See, would you keep that possibility also in your mind? L23 for radiculopathy also? Possible. Okay. But first possibility is femoral neuropathy. Agree with you. Okay. What do you want now?
MRA nerve conduction.
Okay. Nerve conduction will be the first thing. No, that's a femoral neuropathy is first thing. So this is a nerve conduction. They forget about the peroneal on the right side, lower limb. I'm not very convinced about that. I think some people, anyway, it appears decreased CMAP amplitude on the right peroneal. But you see, the pickup from the TA was normal. Okay, so that may be due to that some edema or something lower limb. Okay, otherwise, tibial normal, femoral is gross decrease in the amplitude on the right femoral vastus medialis. 16 on the left side, 2.1 on the right side. Then sensory potential is all normal, including the saphenous. Lateral femoral cutaneous now also was done because that could be some involvement of the lateral cutaneous nerve. Also, that is also normal.
Obturator can be tested, sir.
No, operator usually we do not do the conduction. Very difficult. Okay, FA latency normal. Now what do you want now? This can go with the femoral neuropathy, but the snap saphenous potentially was normal. That if sometimes it's proximal demyelinating block in the femoral, that can be missed. But 4 years unlikely to be demyelinated.
MRI of the lumbosacral.
MRI of the lumbosacral region. Okay.
Needle EMG is a Turulot and anti-on cells.
Okay, that's possible that we can do because sensory snap is preserved. Agreed. So MRI was done. This is the MRA sagittal. 2-3 mild is not significant. Axial, this is L1 level, L1, L2 and L2. L2, 3, small, I mean, the L3 is concentrated on L2, 3 because that is a root which is suspecting. A thin cut at that level, that's a 3 picture is coming, they're all normal. L3, L3, F4, again normal. Again, thin cut was taken L3, L4, normal. L4, L5, L5, S1. This is the sagittal cut, axial cut. What do you want now? EMG?
Plexus MRI.
Pardon?
Plexus MRI.
Plexus was also screened that is normal. And the radiologist, this curiously, I did not ask for MRI of the muscle. Okay. The radiologist took an MRI of the muscle. We showed the affection was there on the opposite side also. See, this is the atrophy of that corticeps on the right side. But left side is also got the part of the hamstring muscle also showing hyperintensity and fatty infiltration. And that he showed me, sir, the other side is also affected. I was surprised. I clinically did not have anything. See on the right, this is the right side, corticeps. See the left hamstrings was affected. Again, you can find left hyperintensity in the left side muscle. Anyway, whether it is incidental, I do not know. But marked involvement was in the corticeps. Anyway, this he picked up. This was not asked for. That way I showed this also. Picked a fatty in place the left hamstring muscle as well. But anyway, that does not solve our problem. We want to know whether he's got right, what is causing his right corticeps weakness. What will you do now? EMG or something else?
EMG.
Okay. EMG, in fact, was not done because it only showed denervation, no? Typical denervation. That's why I thought I did not, EMG was not required.
CPK and CPK.
TPK can be done because of, but the only thing is that he's got a sensory loss. Were down. Anyway, sensory maybe bluffing, you can take that way. Again, muscle disease confined only to the corticeps and hip flexion is little odd. Other muscles are not affected. And 3 years of mind. 3 years.
MRI of the thoracic cord.
Okay, okay. Why thoracic cord?
Because the femoral.
Because the segment can be segment levels, correct?
Yes, sir.
Yeah, because if you take the L2, L1, L2 segment, that will come under the thoracic region, not thoracic cord, it will come under the thoracic region. So when we say MRI of the lumbar spine, it's screened from L1 vertebra down onwards. But as you said correctly, those segments, the L1, L2 segments coming under the thoracic spine. That is what you're referring to, correct?
Yes, sir.
Exactly. So you're perfectly right. We should screen for that also. So you want MRI of the dorsal spine, correct? Okay. CPK was
Yes,
done
sir.
normal. This is MRI of the dorsal spine. I will show the video. See, it's got a osteopathic at 2 levels, compressing the epiconus at 2 levels. I'll show the better picture later on. And this, you can see the corresponding sagittal and axial coming slowly and bringing down. The blue line indicates the level of compression. See here, the severe osteophyte back on the back side, bilaterally compressing at that level, coming down. Again, coming that side. You see that one? That's the area of compression. That's the area the cord is. And you get hyperintensity within the cord. If the cord is hyperintense, see the hyperintensity within the cord.
ഇനി മുകളിലോട്ട് നിർത്തിയാൽ നോക്കുന്നത് ബാക്കിലോട്ട് മുകളിലോട്ട് ആ ഭാഗം ചെറുതായി
In the picture. See the compression there posteriorly with below that you will see the hyperintensity. That is area of hyperintensity.
ബോഡി ഹൈപ്പർടെൻസിറ്റി ഉണ്ട്
That is hyperintensity with the cord. Okay, this is the one which you see here. Can you see the hyperintensity in the cord? And that is osteophyte. That is the compression there. See that one. So that's a lesson. That's a lesson is that whenever the root, so-called root is affected, if it is normal, and the other clue is that snap is normal in this vision. That tells you the lesion is proximal to the ganglion. Okay. So if that is, that means it has to be in the root or the segment. The root is coming in the cauda equina. Cauda equina region is normal. So when that is normal, always look for the proximal part of the root that is come under that is in the thoracic cord, not thoracic cord, and the thoracic spinal region in the lumbar cord. See, the L1 root is coming by the side of the lower part of the spinal cord, and then join the forms the cauda equina. So when you take a spinal MRI, it only screens from L1 downwards. But above that portion where the segment is coming down, that will be missed. So always ask for the lower dorsal spine, the dorsal spine also. Otherwise, you will miss a lesion in the corresponding segment. Take a lumbar MRI itself, normally then walk off. What do you may lesion above? So what do you like to do in this patient? Surgery. Let to do surgery. Otherwise, it's going to further progress. Already is progressing. So any questions?
He had a pain in the knee also, some dysesthesia, no? Like a
Yes. He got a
muscular pain.
He said it burning pain in the knee. Correct. You are perfectly right. He had no root pain. He said burning pain.
So, sir, what's the cause for the atrophy of the opposite muscle hamstring?
It is affecting bilaterally. See, in fact, if you, I'll show that picture once again. The cord is affected on not only one side. Maximum is on that side, but cord is compressed on both sides. I will show that just a picture. I usually see this one. This was taken bilaterally, and the cord is hyperintensity is there bilaterally. That is on the left side. Right? See, that's on the left side. That is on the left side. That is coming like this. That is going to the other side also. That is the area affected.
But what is the level, is there? This level? What
Level
level?
is same corresponding level L1 to L2. This is the area which is affected. For that, you should take the previous, let me see the previous one. That is not clearly shown here. You should count, then only get it. This is somewhere speed. This must be L1 also. This is D11, D10, 11. In fact, the two levels are one above and one below. Wait, wait. This one above and below one. See that one. Okay. Any questions?
The left-sided reflexes were also reduced also because of the
Yeah.
same segment.
Correct, correct, yeah. But only thing is that we do not know the previous state. Is empty individual, we do not know the previous, and very difficult to say. Whether that is abnormal or not, it is difficult to say clinically because there's no complaints pattern, there's no weakness, no sensory loss. And we do not know his previous reflex status. So it's very difficult to say. Okay, shall we close or go for one more case?
One more, sir.
So
Okay.
just between the epiconus and conus, can you just elaborate?
Yeah, the epiconus, in fact, this term is only purely arbitrary for the neurological condition's sake, not anatomical definition. Anatomically, the cone is defined as the lower tapering under the spinal cord. It does not define which segments it includes. For practical purposes in neurology, we divide the lower part of spinal cord into conus and epiconus. Epiconus means the conus means the lowermost four segments. That is S3, S2, 3, S3, S4, S5, and coccygeal. The lower four is called the conus. Okay, that where is under the bladder fibers and down. The one above L4, L5, S1, and S2, they are called epiconus. But this purely arbitrary. That does not mean that a conus lesion is confined only to the conus. It can go up and go to the epiconus. Suppose imagine a lesion arising in the conus region. See, this is applicable mainly for intramedullary lesions. Lesion arising in the conus, which is going upward. It can present with initially a lemon bladder, then no weakness, then ascend upwards to the S1 segment. Then it gone on to the epiconus, lower epiconus, it produces plantar flexion weakness, angle jack will be absent. Then again, little more go to the L5 segment, it appears the dorsiflexion weakness. Still upward, it encroaches onto the L2-34 segment, knee jack become absent, cortex will be weak. So it's only arbitrary. It all depends upon where this lesion is. As the lesion grows upward, you get, so it might, suppose lesion extending up to the L34, you mimic a chord icon. So you cannot just differentiate a bilateral chord icon lesion from a conus epiconus lesion. If the lesion happens to extend above L5 segment, sometimes you get upgoing plantar. If upgoing plantar is there, it can definitely say it is not a chord icon lesion, it has to be a lesion, the conus epiconus. Otherwise, it mimics chord icon lesion.
Thank you, sir.
Okay. Suppose lesion is confined only to the epiconus. Suppose, for example, in this particular case, the lesion happens to be say L2, L3 segment. Okay, epiconus is L4, L5. Still above that, we don't call epiconus. Still above that, the lower part of the dorsal column. If that is affected, that area is affected, then you get everything below that will be pyramidal lesion. But the lesion happens to be extensive downward inside the cord. That is why you got element finding.
Which is the lowest level where you can have the this plantar upgoing, sir?
To get plantar above lesion has to be above L5 segment.
Above L5.
Above L5. Suppose the lesion is there at L3, L4. You can have upgoing plantar and angle will be brisk. Okay. Suppose the lesion is coming up, extending from above or up to the L5. You can have angle brisk, but plantar is mute or even flexor. Okay. Then if the lesion comes down to the S1 segment, then angle also will be lost, but bladder will be UM. You get a hyperreflexive bladder because that is UM above S3 segment. The lesion coming down to S3-4 segment, LM bladder. Element means that hypotonic bladder, large volume bladder with a dribbling. And anal reflex will be absent. The lesion is above S2, then anal reflex will be preserved. Sphincter tone will be retained. So depending if you want the localization easy to remember, which are the site responsible for the function, you can localize these.
Saddle anesthesia will be there, the corners alone.
That can there even be above because the classically if only saddle anesthesia is there, it can be least in the corners region. But a least above also can put his saddle anesthesia because the tract may be affected. See, from the sensory fibers has to go ascend up through the tract, no spinothalamic tract or the posterior column. If that is affected above, you can have also sensation below also. But more important for the saddle anesthesia is the reflex, anal reflex and anal tone. That is the thing which tells you it's more likely to be a cornus epigon, cornus lesion. Saddle anesthesia can occur even if lesion is above. Because the fibers ascending may be involved. You got the point?
Yes, sir. Yes.
Yeah, because the fibers has to go up, no? So above lesion also can put saddle.
So here the positive fights are atypical. They are compressing the cord from the posterior.
Posteriorly, correct. Actually, this is an apophyseal joint osteophytes which is compressing behind. It's not the classical disc. That is, it is affected very unusual way. So many discs we have seen. How many produce hip flexion weakness? When you get a hip flexion weakness, the lesion is not in the hip quad icon at all. It has to be above. But to produce hip flexion weakness, L1, L2 has to be affected. On the quad icon, L2 only downward. L1 is not there. The hip flexion is weak, you have to think lesion above. That is another point which makes you suspect the lesion is not in the quad icon. If there is this compressing, pardon?
Abduction and adduction were spared, no?
Correct. Spared.
Yeah. Usually the adduction will be involved, no? If it is L3.
Yeah, what is said is correct. That segment affection you expect to be adduction to be involved. But it's more, this is affecting only, it all depends upon which are the neurons affected within the intramedullary lesion. That does not behave like a root involvement. Just like the previous case which I showed you, the only he has got a fasciculation coming in the biceps. At the same time, everything other is normal. Only that group of neurons irritated. So similarly, the involvement is patchy even in the case of anterior constant loss. They need not respect a true segmental distribution. It is not as if we are cutting with a knife in the particular segment. Only part of the anterior constant will be affected. And again, the corticeps is not very mildly weak, not severe weak.
Sir, one doubt.
Yeah.
Sir, theoretical doubt.
Yeah, please.
When we say coda icona, minimum requirement is how many roots or bladder, how much deficit should be there to say it is coda icona?
Okay.
With a single root, we cannot say, no?
Yeah. What you say, this I used to take in my class. The term coda icona is only an anatomical term. One should never say coda icona lesion as a neurologist. You have to specify which this is L4 L5 radiculopathy or L5 radiculopathy or L5 to S3 radiculopathy. Because even single root also is coda icona. Suppose S1 radiculopathy is there, it's also called icon. You can't say one root affected by it's a part of icon only. So if only this many roots are affected with icon, is not correct. Because the root forms a icon is an anatomical term mimicking that it looks like a horse's tail. It does not specify that tissue should be this number of roots are there to code. It's not there at all. So as from the anatomically, they can deletion is within the icon, and that carries no meaning at all as far as a neurologist is concerned. You have to specify these are the roots affected. Okay, then that gives you the clue. Because
Okay,
somebody has got L3 root also icon, L3 root also icon.
Okay, sir.
Okay. I'll show one more short case and then close. Okay.
Okay, sir.
It's also a very short case. Complaints of pain in the left side of the neck radiating to the left shoulder for the last 6 months. Not increased by coughing and sneezing. Pain increased on lateral movement on extension of that, or that's on leading question. So pain in the left side of the neck and arm. No radiation to the left arm. According to him, the weakness is mildly progressing. Only 6 months. So examine, look for any granules are all normal. Movements are not much of a restriction movement to either side. There is no pain. Swelling test was negative. Then from the exam is the motor system. Look at the wasting on the left on the deltoid. And left biceps also wasted. Tone normal. Right deltoid is normal. The see deltoid is grossly weak. Shoulder elevation is normal. Shoulder shrugging normal. Deltoid is weak. Biceps is weak. On the left side, normal on the right side. Brachyradial is normal on the right side. Weak on the left side. Triceps normal on the right side. Left side normal. External rotation normal on the right side. Is weak on the left side.
Very good.
Internal rotation normal. Wrist muscles are all normal. This is normal. Finger extension is normal. Finger muscles is normal. Extensor policies normal bilaterally. See the supraspinatus, they're also weak on the left side. Supraspinatus on the left side. Then the trapezius is normal. There is no winging of the scapula. Then anterior. Again and back. Normal serratus. Lower limb is hurt on normal. Reflexes, biceps normally on the right side, left side is absent. That is affected side. Supinate also absent on the left side. Triceps is also absent on the left side. Normal on the right side. But just suitable on the left side. Finger flexion normal. Abdomen reflex is intact. Knee and ankle jack normally elicited. Ankle jack was not elicited, diabetic also. Plantar is intact. Sensation was normal. Is it correctly? Look for any sensory loss anywhere normal. There is no level of sensory impairment. The deltoid also. Vibration sense normal. Joint sense normal. Check for the over the left incision again. There's no change in the difference. I expected a pain loss on that area. So find is confined to the left upper limb, wasting on the left deltoid and biceps. Weakness left deltoid, biceps, brachioradialis, left supraintraspinatus. Triceps and other wrist hand muscles normal. Normal proximal elevation to pieces serratus anterior. DTR upper limb normal. Right triceps supinated just elicitable. Left biceps supinated absent. Left tricep sluggish. Both ankle flexion absent. Lower limb knee jerks normal. Ankle jerk absent. Sensation. No decreased sensation of left up. So what is your localization? Well, go back to the history once again. Pain related to the neck for 6 months. Pain increased lateral movement extension. No radiation left arm.
Left C 5, 6, C7 radiculopathy.
Why C7 radiculopathy? He has got, if it is C5 is radiculopathy, you expect the serratus and to be weak also.
Upper trunk plexopathy.
Yeah, it's more the findings is as your upper trunk plexopathy, right? Okay. Any difference of opinion? Okay.
Upper trunk is only 5, 6. Here, triceps jack is also diminished.
Just diminished. Not absent. Triceps power is normal.
There is a contribution of C7 for the triceps.
Yeah,
No?
right.
C6
Yes.
also.
Yes,
C6
yes,
also.
yes.
Okay.
Triceps, these also contribute to the triceps. But more important is that the power is normal. Triceps power is normal. So what do you want now?
So what is cause for pain while moving the neck? Because this is
He's an old man, maybe that.
Flexitis can produce pain.
Yeah, Praxedis also can produce pain. So is it neurologic hematrophy?
Possible.
Okay. So anything odd? That odd I will come later on.
There's some words
NC
long duration, no?
Correct. It is long duration, 6 months duration. That is why I showed you that history once again. NCS was done, which is not. Then what will you do now?
MRI, sir.
Pain. There is another clue is that is pain.
MRI of the plexus, sir.
Pardon?
MRI of the plexus you have to do, sir.
Yeah, I can do the plexus also can be done. But I did not do that, it's something else. See he has got a disc compression multiple level, mainly at C5, C6. As Mohan sir was telling. And I did the flexion picture also. That is markedly, this is the, see, this is C3, 4, 5, and 6. This is the compression of the cord. And you can find the hyperdensity also. This is also hyperdensity in the ischemic anticonceptive loss. See the axial cut I will show you. This is a cord compression. And this is hyperdensity within the anterior console. This is a neutral position. And see the flexed position, you can make out the hyperdensity in the cord very well. Here is hyperdensity here. It is compressing from front and back. So as Mohan, it's actually compressive cord with anterior console loss. Now, what was the thing which made me do an MRI cervical spine in the flexion filling? Because he was complaining that one long duration, 6 months.
pain with movements.
And he said his pain was more on extending the neck. That is the thing he came like. So the odd point still exists. Why is the other two, the serratus and is pain? That is mainly because the C7 root is pain. That may be the only explanation. We expect to be involved, but so the serratus is supplied by C5, C6, C7. Sometimes the main contribution may not be from C5, C6, maybe from the C7. That may be the reason why, despite the other muscle affection C5, C6, serratus and is pain.
This case can be advised surgery.
This has to be surgery has to be done. Otherwise, it's going to progress. It's already got weakness now. The weakness may not improve. See, they already done the ischemic. See, otherwise you have to put a collar all along. That is impractical. So this patient needs, sees multiple level, not only single and multiple is affected is there.
Sir, can this be Hirayama? If this is Hirayama disease.
No, this is not Hirayama. In Hirayama, actually you get the posteriorly, the dura will be shifted anteriorly. You find a hyperdensity posterior to the dura. That is not seen here. See, flexion extension film is required for disc also. Sometimes you find the disc bulge may be small. Okay. And you may think that, oh, that is not going to cause any problem. Your cord also may be normal in the neutral position. You have to do not only in the flexed position, it's also in the extended position. Sometimes the posterior osteophytes or the apophyseal joint, just like the previous case I showed you, if it is the neck, if you do the extension, you get compression will be more. Some time back I showed one case, during extension the compression is made prominent. And if the disc is anteriorly compressing, then you have to do the flexion movement. So whenever you get suspected lesion in the cord CFS level, and you find the cord MRI take apparently normal, don't stop with that. Do the flexion film as well as extension. See, for example, here this is the flexion film. That is it become very prominent here. Hypertrophy is also very prominently seen.
If the patient is not progressing over a period of 6 months, can we wait?
No, it's better not to wait. And the problem is that anticonceptive loss is lost. Suppose it's going to progress again, the wasting is setting in. That's not going to reverse. So better to prevent further progression.
So one doubt, sir.
Yeah.
So the Hirama usually see the C8 T1 segment, no? So can we see in C5-6 also, sir?
Yeah, what you said is correct, but perfectly that is even the C8 D1 segment is affected. That again you can't call it a C8 D1 segment. That's a peculiar distribution. That is a brachioradial is paired and the oblique atrophy is there. Main affection will be in the lateral part of the medial part, something like a split hand syndrome. So that pattern is due to an antecondylar affection. Okay. The antecondylar is how is affected, most likely ischemia secondary to the pressure effect by the dura anterior. Some of them do develop later on that kind of pyramidal sense also in Hiraya. But as I said, the usual site is distal part of the C8 D1 segment.
So do you subject this patient to Hirayama for spinal fixation?
Yeah, it should be done. Ideally spinal depression is the ideal treatment.
For all cases or patients who progress only or for all patients?
That's again a big question. Suppose the usual situation is usually a person who have got a long neck develop, and usually in juvenile that age group. And sometimes they come to you with years later with static course that upper, I don't know the place. But you got any pyramidal signs or significant compression of the cord in this there, better to do surgery. Because we do not know whether it's going to progress or not.
Okay. Okay.
But having said that, I got a patient whom even the surgery, this whole surgery came only recently now. So this boy, I have been following up for the last 10 years or so. He comes regularly, meticulously. He's only some neural vitamin. So I asked him to come for follow-up, and I want to say progress. He never progressed. Such a patient no need to do surgery. Because it's, we over time we know, but is any evidence of progression, then it's better not to wait.
Sir,
Okay. So yes,
sir, in this case, we have kept DDA as upper plexus, no, sir?
correct.
Sir, sensory is completely normal.
Yeah, that's again the involvement is actually in the anterior constant. Okay. What had
Yes.
happened is that the cord is compressing and produces ischemia to the anterior constant.
Yes, sir.
That is, there's no pyramidal signs in this patient. The cord
Yes.
respect, yeah.
The strictly unilateral presentation is
Very odd, correct?
very
What
odd.
is correct? Very odd. They
Is
always
it due to involvement of the sulcocommissural artery?
maybe you can postulate that way, so, because that's also playing only one side. That's the thing you have to consider. No, that's why neurology is always like this. No case will be exactly same. There'll be some odd point. You have to catch hold of that old point. The odd point. The odd point here is that one is long duration. And why I suspect he was complaining pain on extending. That should not occur with the brachial device. All other things are procured with a typical upper trunk involvement. But extension why should produce pain? That is a odd point. So that's something point with there in the history which should make you think otherwise. So very oddity, you have to think otherwise.
Sir, this patient also has absent ankle jerk.
Pardon? And that is because
Absent.
it's an old man, diabetic, no? So it can not be necessarily correlating. He's 70-year-old or something.
So the first case you showed some EMG discharge. That is myocardia.
Not myocardia, that's fasciculation.
Fasciculation. Okay. Right.
Only fasciculation. Something like a motor unit firing. Only thing is it's not a voluntary activity because it's occurring at rest, and motor unit firing will be in a rhythmic fashion, semi-rhythmic fashion. It's not like that. It comes in a burst, someday comes in burst and goes like that. Some days one potential come, someday three will come.
Complex repetitive discharges.
No, that's different. That's a fast frequency discharge. This is not like that. The one tuck, 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 like that it comes.
Sir, regarding
Yeah.
the patient with tropical ataxic neuropathy, sir.
Yeah,
So what
right.
is the treatment given to the patient, sir, that female patient?
What is that?
Treatment given, sir.
Yeah.
Tropical.
In fact, I have written a paper on that. I collected 40 such cases of tropical ataxic neuropathy from central Travancore. The etiology posted was tapioca, that may not be there. Whatever it is, these people are tapioca eaters, but predominant diet is tapioca that is grown mainly in the central Travancore. Now, what exactly is causing that? What I did at that time was I estimated the arsenic level in the urine and blood of these patients and compared with the arsenic of nerve and blood of the persons who had died during accident, and found that this was, I think, Umar and Murali was my for this. This arsenic level was elevated in these patients, in the urine as well as in the nerve. So it's something to do with the arsenic. And the previous studies have shown that the arsenic content of tapioca is high compared to the other. One more story, interesting story I'll tell. This wife only told me. I was wondering why this tapioca is. See, if you look at the cow is grazing on the field, cow will eat any leaf except the tapioca leaf. That it will not touch the tapioca leaf. So it knows that is some problem is there. So this is why my wife only told me this story. So that also made me think whether it's due to something with the tapioca. Anyway, that is sideline. So we do not know. So one point is arsenic, but the arsenic is not the only factor.
Cyanide also, cyanide content also.
Arsenic content, not cyanide content. Not arsenic, cyanide. I forgot, sorry. Totally. It is a cyanide content, not arsenic. What I meant was only cyanide. It came as arsenic to me. Okay. The cyanoid can cyanogens. Cyanogen is the one which is present in the tapioca leaf. But those who all consume tapioca will not have tropical neuropathy. So some other factor is there. So that was the thiol, the detoxification for the cyanides by the thiol group, that is sulfur-containing amino acids. When that amino acid is not there in this patient, by nutritional deficiency, the detoxification of the cyanide is at fault, and they are the one who are likely to develop this toxicity. Now, the treatment is supply the micronutrients so that the thiol group is made available for this patient for detoxification. So all these patients have treated. They do improve as far as peripheral neuropathy is concerned, but the deafness never improved, and optic neuropathy only minimally improved. Neuropathy totally, some of them improved remarkably, some of them very minimal. But what did not improve was deafness and optic neuropathy.
The optic nerve involvement, B12 will produce some improvement.
Yeah, but in case there's vitamin all never normal. The present is so classical, severe ataxia, minimal neuropathy. Okay, shall we close?
So this
Okay, good night,
compressive
sir.
myelopathy,
Yeah,
cervical,
please, Parvez.
cervical compressive myelopathy patient. When will you order for this dynamic MRI, sir? Any clinical points where you will be
Yeah,
ordering? Otherwise, for
when
all patients will.
no, when clinically you suspect a cervical myelopathy, okay, or a radiculopathy, you find nothing in the MRI. You find the MRI compression is not there in the routine filling. Then you order for the flexion extension. Or usually what is somebody in my situation, people will come with MRI from outside most of the time. They come with MRI which is usually of poor quality, and you suspect a cervical myelopathy, nothing seen in the MRI which is brought by the patient. But I am sure there is something compression is there. So before ordering a good MRI, I will also ask them if that MRI is normal, is in the neutral position, kindly do flexion extension. That is the instruction I give the request form.
So it's mainly for the second study, not for the primary study.
You can do the first also, but by the time, if you can write like this, if the neutral film is not on compression, kindly do flexion. That you can write in the request form also.
Okay.
Sir, many patients, the canal diameter will be only minimally reduced and the code will show signal changes. Such
Right.
patients are benefited by surgery, or we should not subject them to surgery.
If the canal diameter is the one which contributes to the problem, if any canal diameter is decreased, that is the patient indicates surgery. If you take the
But some patients will have normal or near normal canal diameter, but there will be classical the signal changes like pancake signal
That-
changes, but
yeah, that requires
without much
surgery.
compression.
No,
That
that,
also requires.
yeah, if you got a pancake hyperintensity, that is an indication for surgery. No doubt about it.
Oh, okay.
Yeah, that means they want, or it is getting, that means on flexion extension, it is compromising the cord. Pancake means the disc may be very minimal, hardly any compression. But you get a pancake enhancement means surgery, no doubt about it. Okay.
So very good cases, sir. Thank
Okay.
you so much.
Thank
Thank you, sir. Thank you, sir.
Hello, sir.
Yeah, please, yes.
Sir, I am having two kids, sir. Usually I used to watch in YouTube, sir.
Yeah.
Now since last week it is not, they're not uploading.
The problem this week also it will not come in the YouTube because now what happened? This program is done under FINE. FINE means Forum for Indian Neurology Education.
Yes, sir.
Some change in the top level people who conducting it. So we will be streamlining. Just now before the starting the conference, I talked to the organizers. They said they will stream the program from next week onwards.
Okay,
So
sir.
also
Thank you.
likely will not come to the YouTube.
Yes, thank you, sir. I thought some problem is there. That's why I
No,
wanted
it will
to.
come in the next week. Onwards it will come.
Thank you.
If anyone want, I can give a presentation. No problem. I
Sir,
can when they ask me, I can send whatever is in the slides. I can present the video also. I can send. So
Okay.
you were asked me. I sent the last week's presentation to him.
Sir, I
Yeah.
want.
Okay, okay.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.
Sir,
Good night, sir.
sir. Good night, sir.
Good night, sir.
Good night,
Good
sir.
night, sir.
Thank you very
Good night,
much.
sir.
Good night. Good
Good
night.
night, sir. Good night. Good night.